Assalamualaikum and good day everyone. Welcome back to your week 6 of the lecture. So for this week, we will cover the sedative and hypnotic drugs. Before we start, you need to know the learning objective for this particular topic. First and foremost, you should be able to list down the major groups of sedative hypnotic drugs, basically the three main ones: barbiturate, benzodiazepine, and atypical sedative hypnotic drugs. Besides that, you should be able to describe the mechanism of action of these drugs as well as the pharmacological actions. And you should be able to describe the problems as well as the adverse effects that are associated with the sedative and hypnotic drugs. Alright, when we define the CNS depressions, it refers to the drugs or chemicals that lowers the activity of your central nervous system, continue ranging from relaxation to sedations and followed by to the induction of sleep and able to cause anesthesia. So before we discuss further, you need to familiarize with these three agents, which are the central nervous system depressants. One of it is the anxiolytics, which is the drugs that having the ability to relieve anxiety or your panic disorders. And sedative drugs is a drug that induces calmness of mind, quietening effects, drowsiness or sleepiness, but it does not induce sleep. It differs with the hypnotic drugs, which is the drug that induce sleep, and it will encourage the maintenance of state of sleep that is possible to resemble your natural sleep state as followed by the characterized by the EEG. Alright, what are the differences between the anxiolytic and hypnotic? The differences made only by the dose. The lower dose will cause sedation and anxiety effects. Meanwhile, the higher dose, it can cause hypnotic effect of the barbiturates or benzodiazepine. Okay, so you need to be alert and to be cautious when you prescribe or dispense the CNS drugs. This drug can cause physical and psychological dependence. Example, barbiturates, which has narrow therapeutic index, as you can see in this chart. At higher dose, it will increase the CNS effects, which may eventually cause respiratory depressions, memory impairment, confusion, and can lead to the coma and death at high dose or overdose of the drug. Okay, benzodiazepine, when taken alone, it cannot cause any surgical anesthesia effect or any fatal intoxication. However, an important exception is for midazolam. It's one of the benzodiazepine drugs. Midazolam, which has been associated with decreased tidal volume and respiratory rate. And you need to be alert that at higher dose of benzodiazepine, it will eventually can cause coma. The classification of sedative and hypnotic drugs are based on the chemical structures that produce dose-dependent CNS depressant effects. The major subgroup is the benzodiazepine as well as the barbiturates. The newer drugs, or known as the atypical drugs, have the distinctive characteristics including the anxiolytic buspirone and widely used hypnotic drugs such as benzodiazepine-like substances, melatonin agonists, and hypocretin antagonists that can induce sleep to the patients. Okay, as you can see in this diagram, benzodiazepine and barbiturates can be further classified based on the duration of action of the drugs, which relate to the drug metabolism that we will discuss further in the next slides. Ultra short acting acts within seconds and their duration of actions about 30 minutes. Thiopentals, as example, is one of the anesthetic agents that can be used prior for operations or any medical surgery. The duration of action for short-acting barbiturate is less than 4 hours. Meanwhile, for the long-acting actions, it takes about 8 hours or more. Benzodiazepine and barbiturates commonly in tablet form and also can be present in the vial form for intravenous use, depending on their clinical use. As you can see here, benzodiazepine and barbiturates are well absorbed when given orally. They bind strongly to plasma protein. Additionally, benzodiazepine and barbiturates have high lipid solubility and thereby able to cross the blood-brain barrier efficiently and cause rapid onset of action. Diazepam is the most lipophilic benzodiazepine, have quicker onset of actions compared to lorazepam and midazolam. However, you need to take note, the more lipophilic compound, the more it diffuses out very quickly from your central nervous system to the other lipid tissue compartment. It can cause short duration of actions. However, when it diffuses out to the other tissue of compartment, it can accumulate gradually in the body fat and can cause the high distribution volume and eventually lead to long half-life. Take note, be aware if you want to administer or giving this drug to the pregnant woman, it can cross the placenta and can depress the fetus and neonates. All benzodiazepine and barbiturates are metabolized by the liver. Benzodiazepine are very greatly in duration of action, can be roughly divided into short, intermediate, and long-acting compounds. Diazepam, prazepam, clorazepate, and chlordiazepine are long-acting benzodiazepine. It will converted to active metabolite by hepatic oxidation of cytochrome 3A4 as well as the cytochrome 2C9. The active metabolite desmethyldiazepam, or known as nordiazepam, has half-life more about 60 hours. The short-acting compounds such as lorazepam and midazolam can be directly metabolized by conjugation with glucuronide and excreted out through the urine. Please take note, to those who have liver problem, especially the old age, and those who are chronic ethanol abuse or hepatitis, can reduce the rate of oxidative biotransformation of certain benzodiazepine, which further can cause accumulation and prolong their duration of actions. Barbiturates also metabolized by the liver into inactive and water-soluble compounds by the oxidation. The elimination of this metabolic of barbiturate is rapid, especially in young people compared to the elderly and infants. It is because of infants, their liver does not completely develop, and to those elderly, their liver less functioning compared to the normal adult. So in these two different populations, the metabolism and elimination of barbiturates a little bit slower than the normal adults. So barbiturates and their metabolites are excreted out via the renal route as urine. In case of overdose, alkalinization of the urine will actually expedite the excretion of barbiturate. So again, in overdose, consider the use of sodium bicarbonate to make the urine more alkaline. Alkalinization will result in more fraction of charged form so that barbiturates and their metabolite cannot be reabsorbed back to the body and hence easily eliminated through the urine. Here is the dose response curve for all the sedative hypnotic medications in one graph. When you look at this graph, this is dose-dependent effect on the central nervous system by sedative hypnotic drugs. On x-axis is the increasing sedative hypnotic dose, and on the y-axis it shows the various stages of central nervous system depressions. You can see that at lower dose, we just talk about sedation, disinhibitions, and anxiolysis, which is the removal of the feeling of anxiety. At higher dose, we start to see the hypnosis, whereas we see loss of consciousness and reduction of awareness, followed by anesthesia, eventually can lead to medullary depression and lead to coma as well as the death. When you look at this properly, the steepness of the dose response curve actually varies among the group of the drugs. Red line here represent the dose response curve for barbiturates, and the blue line here represent the dose response response curve for benzodiazepine. The benzodiazepine, the blue color line here, has the steepness of the dose response curve. Beside benzodiazepine, the newer and atypical hypnotic agents such as zolpidem and other Z drugs also exhibit flatter curve, which are relatively safer for clinical use compared to the barbiturates. Benzodiazepine group of drugs are the first line of drugs that can be used in the management of insomnia as well as the management of anxiety. The most prescribed benzodiazepine in our clinical settings are the diazepam, lorazepam, midazolam, as well as the aprazolam. Actually, there are many more, about 20 benzodiazepine that are available for clinical use. However, they are similar in terms of the pharmacological actions, but the differences only in the pharmacokinetic behavior, which are the most important to look out in terms of the clinical point of view. The most prominent of the benzodiazepine effects are calming behavior, which decrease the anxiety, hypnosis. It also can cause muscle relaxations, anterograde amnesia, and also has the anticonvulsant activity. Suppression of the seizure activity can be occur with benzodiazepine. Usually, it comes together with marked sedation. So, usually in the management of status epilepticus, we'll use the high dose of intravenous diazepam as well as the lorazepam. To be take notes, there are only few benzodiazepine that has the anesthetic properties. One of it is the midazolam. Barbiturate, as redlined here, shows a linear slope which increase in dose higher than needed for hypnosis may lead to state of general anesthesia at still higher dose. These drugs can depress the respiratory as well as the vasomotor centers in the medulla, leading to coma and death. Because of that, barbiturates are fairly toxic and has narrow therapeutic windows. However, some of the time in our medical practice, they still use barbiturate, especially induction of anesthesia and to induce coma. It's usually they perform it in the critically ill patients and traumatic brain injury. So thiopental and phenobarbital will be used for therapeutic coma. In this state, the patient's brain activity is closely monitored and the level of drugs are adjusted accordingly to ensure that brains remain in a state of rest. Barbiturate comas can also be used to protect the brain during major neurosurgery. It's because the barbiturate as central nervous system depressant reduce the brain activities, allow brain to relax, and consequently will facilitate the recovery of following surgery or during the cerebral ischemia. Usually, patient will put into an induced coma to allow the brain activity to calm down and facilitate the recovery of the brain. Besides that, barbiturate also can be used as last line of treatment for emergency treatment in status epilepticus that have not responded to any other treatments or drugs. So before we discuss further, you need to know that refractory status epilepticus is a medical emergency which continues seizure lasting more than 30 minutes. Beside that, this status epilepticus also can be defined as 2 or more seizures without full recovery between those episodes. So to those who are in the refractory status epilepticus which not responsive to any other drugs, the worst case scenario, thiopental will be given to that person. Okay, bear in mind that barbiturates, although classified as sedative hypnotic, it should not be used to induce sleep and calm anxiety because it's quite dangerous. So the use of barbiturates for sedative and hypnotic is no longer recommended. One of the main reasons, narrow therapeutic windows. Besides that, it also can cause abuse of these drugs. So one of the barbiturate most obvious side effects is hangover after effect, which can result in dizziness, drowsiness, amnesia, impaired judgment, and also disorientation. Additionally, tolerance towards barbiturate can develop relatively quickly. So there will be high dependence on barbiturate, which will cause abuse. Barbiturate, also known as potent inducer of hepatic drug metabolism cytochrome P450, that significant can cause drug-drug interactions. Insomnia is often considered as a disorder of excessive activation of the arousal system of the brain, or we know it as hyperarousal. So hyperarousal in the physiological, emotional, or cognitive network is believed to prevent the sleep regulatory process from naturally occurring in patients with insomnia. This hyperarousal can be detected or examined using the EEG and physiological measure during your sleep and wakefulness. EEG indicators for hyperarousal include the increased high frequency of EEG activity in beta and gamma, decrease the delta activity, which is the non-REM state, and increase the REM EEG arousal. To make it clear, non-pharmacological treatment should be considered first prior subjected to any pharmacological treatment. So we have the non-pharmacological therapy such as CBT, cognitive behavioral therapy, sleep hygiene therapy, sleep restriction therapy, as well as the stimulus control therapy that can be used and should be as a first line and tailored with the patient factors and cause to the incident of the insomnia to the patients. Jet lag consists of fatigue, sleep disturbance, headache, and difficulty in concentrating is due to the mismatching of the body clock, which is the circadian dysrhythmia, against a new time environment with its own time cues. Night work causes more serious sleep difficulty than jet lag because hypnotic drugs cannot be used for a long period of time. So, to those who regularly to receive the night shift, they need to have a short non-drug induced sleep during the night shift. So this can improve the efficiency toward the end of the night shift and reduce sleep needs during the day.